Welcome, everyone. I'm just going to wait another 10 or 20 seconds as people continue to file in. Thank you all for being here. We will get started in just another minute or so. Okay, so while we are waiting for everyone to come in, I am going to go ahead and just give a little bit of background information about the presentation today and how you can ask questions if you have them, and then we'll just go ahead and dive in. So for those of you that are joining, you will see at the bottom of your screen that there is a Q&A function. Please use that Q&A function to ask any questions that you have. You can feel free to put them in as we are talking. We may not answer them until the end, but if you have a question that relates to something that someone is talking about, please feel free to just put that question in there. You don't have a chat function, so we won't be able to communicate with you that way. So again, if you have any questions, please make sure to just put them into the Q&A box. We will, at the end of the show, leave about 10 to 15 minutes to answer questions live for you. And if something comes through that is quick and easy for us to answer, we'll also try to answer that as we're going through the slideshow. But for the most part, questions will be answered at the end. So we'll be monitoring that as we go. All right, so I think we've got a quorum here. So I'm just going to go ahead and dive in. This is everything you need to know about remote therapeutic monitoring, care management, and telehealth in the proposed 2022 Medicare physician fee schedule. Although my screen or your screen is going to tell you that I am Carrie Nixon, I am actually not. I am Caitlin O'Connor. This is just the account we use for our webinar presentations. So my name is Caitlin O'Connor. I am Senior Counsel at Nixon Gwilt, and I am also the RPM practice lead here. So I wanted to make sure that we had a chance to talk to you all about the new remote therapeutic monitoring codes that are proposed in the 2022 Medicare physician fee schedule proposed rule. So that's what I will be talking about. I'm also joined by my colleague, Rima Taneja, who is also a national RPM expert. She's going to be talking to all of you about the care management codes, in addition to RTM that have been proposed. So there have been some expansions that are proposed for chronic care management, principal care management, and virtual check-ins. And Rima's going to tell you all about those proposals. And then finally, I'll kick it over to Rebecca Gwilt, who is the founding partner of Nixon Gwilt. You will hear lots of really helpful information from her about all of the telehealth related proposals in the rule or in the proposed rule. And really quickly before we get started, I'm going to ask Rebecca to just tell you all a little bit about our firm in case you don't know about us or haven't heard of us before.
Thank you so much, Caitlin. I am so proud of our team here for all the hard work they've done, not only in reading this nearly 2,000-page behemoth of a proposed rule, but in distilling the information down for healthcare innovators whose business models are impacted each year by the evolution of federal policy in the virtual care space. As Caitlin mentioned, my name is Rebecca Gwilt, and the firm that I run, we talk a lot about healthcare innovation. We're the only innovation law firm in the healthcare innovation law firm in the country, and lots of folks don't always know what that means. What it means is that founders, executives, and investors in the healthcare space hire us to help them navigate complex regulatory environments and to access market insights in what we know is a rapidly changing healthcare landscape. This helps them innovate faster and make healthcare better and more accessible for everyone, which is what we're all passionate about. We serve digital health and virtual care companies, life sciences and med tech companies, innovative providers creating transformational change to improve healthcare delivery, and even venture capitalists, accelerators and incubators and early stage founders wanting to prime investments and maximize their growth and mitigate risk, of course. I'm going to take a pause here to read a legal disclaimer, which is one of the least exciting parts of this, but I'll do it quickly. It's not, this webinar is not designed to provide legal advice. It's only informational in nature, and nothing in this presentation should be construed as a guarantee of reimbursement. So thank you for joining us. Like Caitlin said, please do continue writing into the Q&A. We'll be monitoring it. You will have access to this presentation afterwards. And of course, we individually are real people, so you can reach out to us after the presentation. I'd like to hand it back to Caitlin to go over the agenda and kick us off.
Awesome. All right. Thank you, Rebecca. So yes, as Rebecca mentioned, you will have access to this presentation when we are finished. We'll be sending out the recording. We will not be sending out the specific slides themselves, but we will be sending out a recording. We'll also be posting that on our website so that if you know anybody from your organization that signed up but didn't have an opportunity to actually join live, they'll be able to see the recording as well when we send it out. All right, so very quickly, here's the agenda. I'm going to quickly let everybody know what the rulemaking timeline looks like for CMS. As we know in the RPM industry and digital health generally, reimbursement is really foundational to the business model that you all are implementing most of the time. And what governs all of that reimbursement is the Medicare physician fee schedule. So I'm going to just talk to you a little bit about the opportunity that you all have as stakeholders to actually submit feedback directly to CMS on that Medicare physician fee schedule to make sure that the rules they come out with make sense for your business and for patients, most importantly. Then I'll talk a little bit about the proposed remote therapeutic monitoring codes. I know everybody is really, really excited about them. We are as well. So I'm really excited to share with you everything that is in the proposed rule about them and how they are proposed to work. And once I'm done with that, as I mentioned, I'll kick it over to Rima, who will talk to you about chronic care management, principal care management, and virtual check-ins. And then Rebecca will give you lots of really helpful information on the exciting proposals related to telehealth. After that, we'll give you just a couple of key takeaways for you to take from this into your comments that you're going to submit to CMS, and we'll open it up for questions from there. So let's just dive in. Okay, quickly, here is the rulemaking timeline. So if you have been paying attention, you will know that on July 17th, CMS published the proposed Medicare physician fee schedule for 2022. By law, CMS is required to give stakeholders an opportunity to submit comments to them for them to consider before they come out with the final rule. So you'll see on your screen these big red arrows showing you where we are right now. We are in the comment period right now. This is your opportunity to give CMS your feedback on what has been proposed for 2022. And most importantly, they're required to read it. So they have to read the comments that you submit to them, and they have to consider the feedback that you're providing to them. That's why this is also important. This is the only time every year that you get this opportunity to communicate directly with CMS in a way that they're required to actually read it and consider it. After we all submit comments before September 13th, they will take a couple of months to consider all the comments that they've received and all of the feedback that they've received. And then they will come out with a final rule around November or December. So the end of this year with the final Medicare physician fee schedule, which will govern reimbursement for 2022. So that will go into effect January 1st. And for all of next year, we will be following the rules that they come out with at that time. So let's talk about remote therapeutic monitoring. As you may or may not know, CMS has proposed 5 new codes in this category of remote therapeutic monitoring with the intention of allowing providers to now receive reimbursement for monitoring of therapeutic data such as medication adherence, therapy response, and pain. And let's talk a little bit about exactly what those codes look like. So I am not going to dive into in this webinar the specific remote physiologic monitoring codes that many of us are familiar with. If you are not familiar with them, we have lots of blog posts and lots of previous webinars that we've done on them. So make sure you check those out, because I think that remote physiologic monitoring is really important to understand in order to also understand what's been proposed for remote therapeutic monitoring. These codes are very much structured in a similar way to the existing remote physiologic monitoring codes, or RPM. And so understanding those codes will help us all understand what's been proposed for RTM, and most importantly, the feedback that we can give to CMS to make sure that they get these codes right in that final rule at the end of the year. So if you are familiar with RPM, then you know that there is one device code that is specific to providing reimbursement for supply of RPM devices. And there is one code that provides reimbursement for initial setup and education on those devices. We have the same thing here for RTM. They've proposed 3 codes related to devices for RTM. The first is that initial setup and patient education on use of the equipment, which is 989X1. In case you don't know, those X's will be replaced later on in the final rule with actual numbers, but for now, these are just placeholders. That's why they have the X in there. So again, that's the 989X1, which is the proposed code for the setup and patient education on the use of the RTM devices. Then there are actually 2 codes here for supply of the devices to patients. The first is a code that is reimbursement for supply of devices that monitor a patient's respiratory system. And the second is a code that is proposed to provide reimbursement for supply of devices that monitor the musculoskeletal system. I'm going to say MSK a lot in this presentation. Whenever I say MSK, I'm referring to musculoskeletal and that limitation that's set forth in this 989X3. So take note of that because that is very different than RPM, which is a device agnostic, or excuse me, a condition agnostic code that reimburses for any device that monitors physiologic data. These 2 are very, very specific for devices that monitor the respiratory system or the musculoskeletal system. We'll talk in a moment about the opportunities for comment here and the feedback that you can provide to CMS. I think what's going to be most important is making sure that in the final rule, we are not limited to only devices that monitor those 2 systems. And we'll talk about that in a little bit more detail in just a minute. For now, let's focus on the services codes that have been proposed for RTM. These 2 codes are structured very similarly to 99457 and 99458, which are RPM codes. These 2 codes cover the services or the time spent by the billing provider in monitoring data that's collected via those devices and having interactive communication with the patient or caregiver during the calendar month. So as you can see in these 2 codes, they both require 20 minutes of time. I have bolded for you though, this physician and other qualified healthcare professional language, because that is also going to be really important when we consider the feedback that we need to give to CMS about these codes. So keep in mind that these 2 codes are limited to physician or other qualified healthcare professional time. That means that right now they don't include clinical staff time. What has been really, really helpful in RPM for making sure that patients get the care that they need is making sure that clinical staff can help with the actual monitoring of the data that comes in, because as you know, most physicians and QHCPs don't really have time in their day to actually monitor this data as it's coming in. So this limitation, I think, is also going to potentially be a bit of a barrier for patients and for providers, but we'll talk in a minute about how we might be able to change that and the feedback we can get to CMS. So for now, just keep in mind that there are 2 codes. One is for the initial 20 minutes of time that is spent in the month, and the second is this 989X5, which is for each additional 20 minutes that is spent above and beyond that initial 20 minutes. Okay, so I've created this fun Venn diagram here so that we can compare RPM and RTM, so you can see very clearly what the differences are as the codes have been proposed and what the similarities are. On the right side of your screen, that circle is going to tell you everything about RTM and what has been proposed by CMS for the coverage requirements that they want to have in place. So basically for RTM, what CMS has said is they would like to only reimburse for RTM for when it's monitoring non-physiologic data. That is different than RPM, which monitors physiologic data. RTM has also been proposed to allow for self-reported data, which is a really important expansion from RPM, which requires automatic transmission. One big barrier that we've seen in the RPM space is that there are lots of medical devices out there that collect self-reported data or data that the patient reports to their doctor, such as pain levels, some behavioral health data that's really valuable to collect and really important. A lot of that has been left out of the current RPM framework. So I think this expansion of allowing for self-reported data to be collected is really, really valuable and really, really important. Also really important, and another expansion from the existing RPM codes, is that RTM has been proposed to be able to be ordered and billed by providers that are eligible to bill general medicine codes. So where RPM can only be billed by ordered and billed by physicians and non-physician practitioners like nurse practitioners and physician assistants, these RTM codes have been proposed to be allowed to be billed by physical therapists, occupational therapists, SLPs, and other types of providers that are eligible to bill those general medicine codes. So that's a really exciting expansion as well, where I think RPM has really excluded some valuable use cases for RPM. Hopefully these RTM codes will take care of some of that and expand some of those limitations. As we just discussed a moment ago, the device codes under RTM are limited right now to monitoring MSK and respiratory systems. So things like CPAP machines or devices that monitor range of motion, maybe in the knee after surgery, or other types of devices that monitor musculoskeletal systems or respiratory systems. Those are the only two types of devices that right now would be reimbursed under RTM. There is no definition in the proposed rule of musculoskeletal or respiratory systems. However, there's lots of general clinical information out there that gives us an indication what that means. So MSK, if you don't know, typically relates to the bones, the joints, and the muscles. And then respiratory system, of course, relates to the lungs and everything else that it takes to breathe. All right, and finally for RTM, the current construction of the code, which we just talked about a second ago as well, excludes clinical staff. This is really, really important because now CMS is saying for RTM, the providers that are billing the codes actually have to be the ones to spend the time monitoring the data. If you've been in RPM for a while or you're familiar with the history of it, you may remember CPT code 99091, which was the original standalone RPM reimbursement code that came out a couple of years ago. One of the biggest barriers we saw to adoption of RPM at that time was that physicians and other healthcare providers do not have time in their day to monitor data as it comes in. They've got to be able to leverage their clinical staff, like their nurses, sometimes medical assistants, and other clinical staff to help with the monitoring of that data. Of course, escalating any emergencies or anything else that happens along the way to the physician, but leveraging the clinical staff has been really, really important. And also what's been important is being able to leverage that clinical staff on a remote basis, rather than only being able to use nurses that are physically located in the office with the doctor. Being able to outsource some of those services to clinical staff at, say, a third-party RPM vendor has also been really important to making sure that patients have access to RPM and that we see the widespread adoption that can be so valuable to patients. So I think those last two, the limitations on the device code and the current construction excluding clinical staff, are going to be really, really important pieces that we need to provide feedback to CMS on to make sure that they get this right in the final rule. Finally, I will just touch on this middle part of the Venn diagram here, which specifies that both RPM and RTM do require the use of a medical device to collect data. So this means a device that is defined by the FDA as a medical device. This does not mean that it necessarily has to be FDA cleared or approved. There are lots of medical devices that don't need to go through that clearance process. They can either go through a registration process, or they may be subject to some enforcement discretion if they are relatively low risk medical devices. But that's a really important piece to keep in mind as well, because now that we have this allowance for self-reported data and for this non-physiologic data, I think that this really opens up, hopefully, the reimbursement to software as a medical device that is not necessarily a hardware that the patient has to use to take a reading and automatically transmit it to the provider, but perhaps an app that monitors things like opioid use disorder or pain levels in patients to make sure that their medication regimen is working, or even things like medication adherence, making sure that patients are taking their medication if and when they're supposed to, monitoring any symptoms that go along with that. A lot of that self-reported information that we just don't have hardware to collect and automatically transmit. The technology just doesn't exist, but we do have software functions that provide that collection and provide that value that that hardware would if it could. So because those are medical devices, even though they're software, it's really, really important that you keep in mind that it does have to meet that FDA definition. But I do think that there's a lot of opportunity for those software devices to be reimbursable. So I will move now to these outstanding questions and opportunities for comment. I've broken down just a few of the outstanding questions that are not super clear in the proposed rule, or where I think that CMS could maybe change their thinking or provide some additional opportunities when they come out with the final rule at the end of the year. The first and foremost, how can CMS remedy the current exclusion of clinical staff to allow for general supervision for RTM? If you're going to be submitting comments, which you all should, I highly encourage you to think about this. How can CMS restructure these codes, or what's the language that we need to see in that final rule to allow for providers to leverage clinical staff on an outsourced basis to help with RTM? How can they make sure that they can use a third party to monitor data as it comes in and escalate things when necessary? The second is, can providers only receive reimbursement for MSK and respiratory devices? Is that truly what CMS is getting at with the codes that they've put out? And if so, how should they ensure that coverage for other devices that are likely to be used for RTM, and by the way, are really, really valuable for patients, but are excluded by those limitations? So that goes again to things like pain and medication adherence, which, by the way, pain and medication adherence are two data points that CMS says in the proposed rule are eligible to be monitored under RTM, but wouldn't necessarily relate to MSK or respiratory systems. How do we make sure that software functions that are medical devices or other types of hardware devices that monitor those other data points are also reimbursable? How do we make sure physicians can get paid for that? Third, who can bill for RTM? So as we said, CMS notes very clearly in the proposed rule that their intention is for physical therapists, occupational therapists, and other types of providers to be able to bill for RTM. But right now, the construction of the codes is not super clear on that. So how do we make sure that CMS finalizes the rule in a way that keeps that very broad allowance for these other types of providers who have thus far missed out on RPM, are actually able to provide and bill for RTM, because this is going to be really valuable for their patients as well. Fourth, will CMS adopt coverage policies similar to those adopted for RPM? So in the proposed rule, they haven't noted much about a 16-day requirement or some of those other requirements that we know apply to RPM. They haven't talked about those in the proposed rule. So it's important for us to understand, especially the 16-day requirement, whether or not CMS intends to adopt those similar coverage policies. Because if you're familiar with RPM, you probably know that that 16-day requirement in particular has been a relatively big barrier for patients. There are lots of patients out there that don't need to monitor data 16 times in a month, things like weight or other types of data readings that clinically should not be monitored or taken 16 times in a month, traditionally have gotten left out of RPM because of that 16-day requirement. So will CMS adopt those same coverage policies for RTM? And if so, is that going to create a barrier for your patients or for your customers? And how do we make sure that we don't have those barriers in the final rule? And then finally, one of the specific questions that CMS actually asked in the proposed rule is whether software should be included as a practice expense. So practice expense is one of the ways that CMS values the codes that they reimburse for. And what they're asking here is, should we consider software that is a part of these RPM or RTM solutions? Should we consider those in valuing the RTM codes? And actually, they've asked it a little bit more broadly than just RTM, but I think it's really important for RTM in particular. How do we make sure that the valuation of these codes accurately reflects the value of the technology that's used? So we know for RPM and now for RTM, hardware devices and software functions that are medical devices are going to be reimbursed under those device codes. However, there are a lot of times there are software functions that go along with those devices that are also really valuable and cost money that probably should be considered in the valuation of maybe the services code, or maybe in that device code to maybe increase the reimbursement for that a little bit to accurately reflect the value of the technology that's actually being used. So again, those are all the questions that I think we should all be considering. I'm sure there are plenty more. I already see questions coming in the Q&A, so we'll be sure to look through those at the end. But for now, I want to get you all thinking about these particular questions and how you might be able to communicate with CMS, the best way for them to finalize these codes so that all of these potential barriers aren't there, and we make sure that patients have access to these services. And now I'm going to pass the mic over to Rima, who's going to talk to you a little bit about CCM, PCM, and the virtual check-in proposals that we have seen in the proposed rule. Rima?
You're on mute, Rima.
Sorry. Hi, everyone. Thanks, Caitlin. And as she mentioned, I'll be talking about the CCM, PCM, and virtual check-in proposals in the proposed rule. So just to summarize before we get started, under CCM, CMS is proposing to add one new code that would account for each additional 30 minutes of time spent. For PCM, they're proposing to add 4 new PCM codes, and those would replace the 2 existing ones that we currently have. And for virtual check-ins, CMS is proposing to make permanent G2252, which has been used temporarily up until now. All right, we can move to CCM. Okay, so for chronic care management, there's one new code that's being proposed. This would account for each additional 30 minutes of time spent for CCM services, and it could be provided by clinical staff performing these services under general supervision of a physician or NPP, or it could be personally performed by a physician or NPP. So this expands the offerings under CCM because currently there are 5 existing codes, but the code that describes the additional time spent is only for 20 minutes, so this accounts for an extra 10 minutes. Okay, so for PCM, this is where they're offering the most expansion under the care management services. So right now, the 2 codes only account for the first 30 minutes. There's only 2 codes that would require PCM to be provided for at least 30 minutes, and there's no reimbursement for time spent beyond that. So these 4 new codes would allow for billing for the first 30 minutes provided by a physician or a qualified healthcare professional, but also they add a code for each additional 30 minutes spent. So that allows, you know, if a patient's receiving PCM for 60 minutes, for example, instead of the clinician just being able to bill for 1 code for this entire time, now there's opportunity for additional reimbursement. So this would be a huge expansion under PCM. And I think that's showing that, you know, CMS is considering these care management services to be highly valuable. They often mention that they would like more utilization of the care management codes, and this is a good example of that thinking. We can move to virtual check-ins. Okay, so for virtual check-ins, this code has already been being used temporarily. It's G2252. And basically what it allows is additional time spent for virtual check-ins. So instead of only allowing for reimbursement for the first 5 to 10 minutes, this code would allow for a practitioner to bill for the next 11 to 20 minutes. So essentially it would allow for longer virtual check-ins. They are still proposing to allow this to be performed via audio only. So the requirement is that the interaction must be synchronous, but it can be provided solely by an audio technology. So again, this would further expand the care management services as well, allowing for additional reimbursement for longer virtual check-ins. And it seems that this, in CMS's eyes, this code has been allowing patients who are not comfortable going back into a physician's office, for example, to receive extended audio-only services. So this is definitely one that we will want to comment on to make permanent. All right, so obviously the new PCM, CCM, and virtual check-in codes are ones that we'd like to see finalized. There's also one additional opportunity for comment that CMS has posed. So they mentioned that during the PHE, they allowed consent to be obtained under general supervision, whereas otherwise it could only be obtained under direct supervision. So they're interested in seeing how practitioners have been obtaining consent with this flexibility that it can be obtained via general supervision. So I think this would be a good opportunity for clinicians and digital health companies to comment and show that obtaining beneficiary consent via general supervision is a lot more attainable and furthers the industry goal of ensuring that these services can keep being provided without a practitioner necessarily being on site. And that's it for me. And I'll pass the baton to Rebecca to talk about the telehealth proposals.
Thanks so much, Rima. I just wanted to make a quick comment before I get into the telehealth subject matter here. We are watching this, we are watching sort of the arc of the evolution of CMS's thinking on these. It is the case that every year they come out with language that is not ideal for how business models are constructed and sort of operating on the ground. But I am really, really encouraged by the year-over-year expansion that reflects the acknowledgement of CMS, that remote monitoring, that increasing access to virtual care services, that's something that they see value in as they move pretty aggressively towards, in some cases, even mandated value-based payment reforms. So I think that the work that all of you in industry are doing to push them out in that direction, certainly combined with what happened during the pandemic, is just really, really encouraging. So I am I would encourage you to continue to collect data, to communicate to the agencies, to make sure that they understand the real value impact of these technologies on patients. And I'm going to touch a little bit on that, but I would continue. We are winning this so far. So from a telehealth perspective, just as a little bit of background, we're still operating under the waivers that became available under the public health emergency. So this telehealth policy in this proposed rule, much of it is primarily going to be felt after the PHE ends, right? It's talking about permanent changes after the after the public health emergency is over. We still don't know when that is going to be. We have heard that it will be extended by congressional legislation. Certainly the administration can choose to extend it. There's been strong language from the president lately around the Delta variant. So even though this public health emergency is meant to expire at the end of this year, that's very much still up in the air. Also, a quick note that this presentation is focused on, of course, the Medicare physician fee schedule, but many commercial payers follow the same or similar rules as Medicare when deciding their benefits. So this is, I would consider this to be applicable, across the board, whether you're billing federal payers or not. You may recall that prior to the PHE, there were some pretty onerous restrictions on reimbursement for telehealth by Medicare, such as the requirement that the patient be located in a rural or underserved area, and that they be present at a particular healthcare site, which we call the originating site, during the visit. Some of these requirements are statutory, meaning it's going to take an act of Congress to update the rule to change those, but some of these are arguably within the control of the agency. And stakeholders have been pushing CMS to apply creative interpretations of the current law to expand access to telehealth for a while. And we're finally starting to see some of this in this year's physician fee schedule. So the proposals I'm going to talk about today are slightly disappointing, but illuminating developments related to the telehealth code list, the expansion of audio-only services for mental health care services, and then sort of the legislative problem that's getting in the way. And then what I think is incredibly exciting, both on the both on the telehealth and virtual care services, remote monitoring fronts is the decision by CMS to reevaluate the definition of direct supervision for the first time. So let's dig into this. So there are kind of 4 lists when it comes to telehealth in my mind. One list is the big list, right? That's 270 or so codes that were added, that include the original permanent telehealth codes, and then all of the codes that got added during the public health emergency. The second list is a slightly smaller list, and that's what we call our Category 3 codes. And that list was created by the 2021 physician fee schedule, and it's a subset of the codes that are not permanent, but that CMS said we'll add through the end of the end of public health emergency. There's enough clinical efficacy data that we'll accept those. So those are the Category 3 codes. The other codes are permanent codes. Those are Category 1 and Category 2 codes. So that's sort of the background here before we get into what they said on the code side. There is a lot of uncertainty in the industry around these codes, primarily the Category 3 codes, which are those codes that CMS is essentially saying, yeah, they could become permanent codes. We need more data, et cetera. Right now, they're set to expire either in the end of the year that the public health emergency ends, or the end of this year. So again, if the public health emergency gets extended past December into 2022, could be at the end of 2022. But there's still a lot of uncertainty around how that's going to work, and that certainly impacts the business models of the clients that we're seeing when they sort of try to look at the next 3 to 5 years from now. We certainly hope that there's more comprehensive telehealth legislation going through Congress, but it's not there yet, and so there's a lot of uncertainty there. Can we go into the next slide? So in the proposed rule, CMS declined to add any permanent services. There was a list in the rule you can take a look at. I've included some of those here. A lot of physical therapy, speech therapy codes, biofeedback, and some even psychological testing codes that CMS basically said, we know you submitted them for permanent addition to these lists. We're not there yet. We can't accept it. But we will accept additional suggestions to add temporary Category 3 codes. So again, that big list of 270, that's the codes on that list that weren't included in the Categories 1, 2, and 3. Those are codes that are already out there in the marketplace as being performed virtually. If there are any more, certainly CMS is interested in hearing it. And in addition, they're proposing to retain all services on the Medicare telehealth services list that are already accepted as Category 3 codes through the end of 2023. That sounds like a really long time, but in order to get your code on the final permanent code list, Cat 1, Cat 2, you need to submit evidence by February of 2022, right? So you get one more shot at it. What I found really interesting about CMS's language in the proposed rule around this is that it appeared to me that some pretty basic kind of criteria that CMS is looking at when deciding whether to add a code to the permanent list wasn't demonstrated by the folks that submitted proposals in February of 2021. And it really gave a lot of insight into how you could demonstrate that your code should be reimbursed as a telehealth code in the next coming submission in 2022. Can you go to the next slide, please? So just to summarize some of these things, and I would encourage you to read the rule around this section, but the industry opportunities here are certainly to push back on CMS's decision not to accept the listed codes as Category 1 or 2. I think there's an opportunity to do that, to advocate for the addition of temporary codes as Category 3 codes, and then to gather research and evidence on outcomes in a remote environment in particular. CMS is really focusing on patient safety, clinical effectiveness, and the outcomes in delivering those services virtually versus the outcomes of delivering them in person. There were a lot of descriptions of a lot of the justification that CMS used not to add these codes permanently that said to me, commenters really need to look at exactly what CMS is evaluating, and they need to really educate the agency. So in some cases, CMS said, well, we can't add this to the permanent code list because in order to get this done, the patient has to be located in a particular place and someone has to be monitoring them, or someone has to be placing electrodes on them in the correct spaces. Well, we know that supervision can happen virtually. And so the justification of, oh, it can't be done via telehealth because something has to happen at the patient level isn't always going to be a good justification, right? You need to paint this picture for CMS that says, here's in practice what staff is going to be providing these services, whether it's just the physician or billing provider or other staff, how it's done, how you can demonstrate that it's going to be efficacious in a virtual environment, how you put guardrails in place to make sure that patient safety and diagnosis is and quality of diagnosis is at the center of your decision making. I really do think that educating the agency is a great way to move these codes onto this list. All right, let's go to the next. The second sort of tranche of changes has to do with telemental health. So there were some wins and there were some not wins. One of the wins was that they were able to, as a result of legislation that passed in the fall of 2020, propose to eliminate the originating site requirement for delivery of services having to do with diagnosis of mental health disorders. This is great news. This eliminates, from a legislative perspective, the limitation on the location of the patient, right? They can be at their home. That's great news, right? Except for, it appears to me that faulty drafting in this piece of legislation looped in old language, sort of a copy and paste of a very old telehealth bill that requires an in-person visit within 6 months of the virtual visit as a condition of reimbursing that virtual visit. Can you go to the next slide as well? Thanks. The other change was that they are now reinterpreting interactive telecommunications system, which used to require face-to-face video, real-time video, to include two-way audio-only technology for the delivery of mental health services. But again, this is a great win. We can do audio only. That gives us access to folks that don't have solid broadband, folks that don't have smartphones. It really expands access to some of the more vulnerable patients. However, this legislation requires an in-person meeting. So it sort of handicaps the ability to do these, to bill for these services in a completely remote environment. CMS also proposes additional requirements that the distant site practitioner, which is the practitioner that's not located at the originating site with the patient, that they have access to and can provide real-time audiovisual telemedicine services, but that the patient basically has either said they don't want to or is incapable of receiving services using live audio video, and that the patient must be located at home. Again, there's not much CMS can do here to get around what the legislation says. We're hoping for other legislation to correct this and sort of replace this. But for now, the win is that audio-only services are expanding in some cases. One thing I wanted to point out here is that the logic that CMS uses to justify making this interpretation of interactive telecommunications system specific to mental health doesn't really hold water, right? A lot of the arguments they make about broadband access, about the ability to provide services without needing to visualize the patient, that applies to a lot more than just mental health services. And in the inverse, there are some mental health services that should require visualization of the patient. And so I think there's a big opportunity, even if you can't fix this legislative glitch, there's a big opportunity for folks to comment on the necessity to expand this term revision of interactive telecom system to beyond just mental health services. Next slide. And then the last thing I wanted to talk about today, because I want to make sure you guys have time for questions, is this proposal by CMS to reconsider the definition of direct supervision. This could be a really big deal. They're asking whether they should make what's available during the pandemic, during the public health emergency, which is the ability of clinicians to provide remote direct supervision so that non-physician, non-NPP providers can bill incident to those physician services, and whether they should make that flexibility permanent. This would mean that telehealth companies whose models are built on the use of an array of clinical staff, not all of whom are able to bill all E&M codes, to receive direct remote supervision by the billing practitioner. Again, the impact of this is going to be felt after the expiration of these PHE waivers. Again, this is something that's going to expire either this December 31st, or if the PHE is extended into next year, at the end of next year, unless they decide to permanently amend this definition. I would just point out here that there's special importance here for physical therapists, occupational therapists, and SLPs, because they are currently unable to bill Medicare directly for E&M codes, but can bill incident to. Once this flexibility ends, if CMS doesn't adopt this new definition, that business model, which we've seen perpetuated in the virtual care space, will kind of fall apart. So another area to really make sure that you're commenting on. So there's just a couple of, a couple of all of them that are out there, comments that I think that folks should be looking at. One, of course, are there codes on the temporary code list, the Cat 3, the temporary the temporary code list. It should say telehealth, temporary code lists that are not added to the Category 3 list that should be added to the Category 3 list. Are there codes that were rejected on a Cat 1, Cat 2 basis that should be reconsidered? And a lot of support for CMS extending the coverage of the Cat 3 codes through 2023 or even beyond it. Again, I think comments on whether audio-only reimbursement should apply to all mental health services. There were some comments about whether it should only be a select few services, whether it should not be available for level 4, level 5 services, and also comments on what other non-mental health services are unlikely to require visualization of the patient, where you could get as high a quality service without visualization as you can with visualization. CMS, again, has said, we get it. We really get that you can do a lot of talk therapy, right? This is their level of consideration based on what I read. We know you can do talk therapy, and that's very common. And so we're going to say audio only is okay for mental health services, but everything else we think pretty much requires visualization. I just don't think that that's necessarily the case. So lots of comment opportunity on that. Again, if the legislation changes, then we may have more opportunity to fix that. But I think the more we hammer on this point, that the more we have the opportunity to open up audio only services for so many patients who don't have access to audiovisual. And then the last is, how important is remote direct supervision to your model? And tell CMS that. How is it important to patient access? How is it important to specialty access? How does it impact patient safety, if at all? How is it conducted? Who's doing this? What is the business model look like? How do you make sure that there are guardrails to protect against the things that CMS is scared will happen to beneficiaries? And they've also said, well, maybe we'll extend it, but maybe we'll only extend it for particular services. I would advocate that whatever service you provide, at least, that service, if in your estimation, you can still provide high quality services that way, that you tell CMS that, and really, again, help educate them, not just telling them what the service is and one or two pieces of evidence, but really explaining the model to them. This is where we found really great success on the RPM side in changing CMS's wording and changing CMS's thinking around these policies, is helping them understand the benefits and the real life sort of on the ground implementation of these models. And last plug, not all of you can afford lobbyists, but you absolutely can reach out to your advocate at the legislative level. One way to prevent CMS from making rules that don't make sense is to prevent bad laws, badly drafted laws that CMS then has to sort of grapple with in the rulemaking process. So I'll hand it over to Caitlin to talk about some key takeaways, and then we'll take questions.
Awesome. Yeah, so we have some key takeaways here. I'll just read through the RTM ones, and then Rima and Rebecca, if you want to take yours, that's great too. So for RTM, I think the main takeaway is there's a great deal of uncertainty that CMS is going to need to clarify. You all have already been asking lots of great questions in the Q&A that we didn't get to in the presentation, but that are other points that we should make to CMS. Things like, can RTM and CCM be billed in the same month? Or can RTM and RPM be billed in the same month? Things like that are all really important points to point out. And you know, we've got kind of the base language in the proposed rule, but I think there's a lot of opportunity for us to ask CMS for clarity there. Rima, do you want to take the CCM, PCM, virtual check-ins takeaways?
Sure. Okay, so for CCM and PCM, as I mentioned, it's really an expansion of these codes to allow for more time spent under these services. And so it's a great opportunity for digital health companies to offer these services to help facilitate the provision of these services for their customers. Similarly, under virtual check-ins, G2252 has already been used temporarily. So it's another example of CMS seeing where these care management services can really push forward in coordinating care for patients who are now using virtual and digital health services more commonly. So I think all in all, these care management codes these new codes are indicating that CMS is thinking about this in the long term.
Awesome. Rebecca, do you want to take the telehealth takeaways?
I feel like I just went over them. Okay. I think you guys probably have it. Let's dive into questions.
Awesome. All right. So yes, we've gotten a lot of questions. Like I said, some of them are definitely pointing out things that we didn't get to in the webinar. One question in particular that I do want to touch on because we didn't get to it is whether or not there's a proposal in the proposed rule for RTM codes or RPM codes to be billable by FQHCs and RHCs. Unfortunately, the answer to that is still no. In the past, we know that CMS has very clearly said that FQHCs and RHCs cannot bill the RPM codes outside of their outside of their AIR or prospective payment. That has been a huge barrier to rural populations having access to RPM. They didn't mention anything about FQHCs and RHCs for RTM in the proposed rule, but I have an inkling that they will probably have the same take on that. So it's a really good point that I definitely think that people should bring up in comments because I don't want this barrier to carry over to RTM. And also I do just want to very quickly let everyone know that because a lot of people are still asking whether or not they're going to get these slides after the presentation. I want to just quickly remind everyone we are going to send out this video, so you'll be getting that. You'll also get a link to our website where we talk about the fixed fee offering that we are providing for comments. So if you want help with drafting your comments and submitting them, let us know. We're happy to help you with that. And like I said, you'll get a link to that right after this, so you can read all about it. All right, some other questions that we are getting here are about, most of them are about RTM. Let's see. Do you expect other systems beyond respiratory and MSK to be included in RTM? I hope that they will be. The proposals right now, like we said, are very limited, but as we know, there are lots of valuable use cases for other types of devices for therapeutic monitoring, for things like pain and medication adherence. I think it's crucial that CMS provide reimbursement for those types of devices. And so I think what we need to do is make sure that in our comments, we're very clear with CMS what that value is and that they should expand that reimbursement for other types of devices.
Yeah, I'm seeing a question here about, which I'm getting a lot of questions about this lately, about how the proposed rule may help a text-based conversational AI-driven CBT delivery product or app. So this presentation, we're focusing mostly on Medicare. For Medicare, they're just dipping their toes into the water of maybe audio only, but definitely live is required. I don't think CMS is prepared to talk about sort of text-based telemedicine services, although our team is absolutely having conversations right now about how to influence federal policy about AI in healthcare. It's definitely something that CMS is looking at, and we have our eyes open and our ears open for how they are evaluating this. It is the case that CMS is not going to be reimbursing for a text-based chatbot, even if it's very high quality, just in the near term. It's absolutely something you should start the conversation with them about, right? They have to read all of these comments, even if it's not something that they're going to adopt. The more they hear about it, the higher it becomes in their consciousness. So I would absolutely say, take a look at it. I do have a concern that we're going to start to see enforcement actions in the text-based telemedicine space. There are various states that require, in order to form a physician-patient relationship, that require at least a face-to-face live visit with a clinician. And there's a whole range of companies out there that are doing 100% text-based and then some hybrid. And I think we're going to start to see enforcement against 100% chat-based telehealth companies who are out there. Now, whether that's at the state level or at the federal level first, it is not something I can predict, but I would be really careful if you have a chat-based model to make sure that you're talking through at least understanding what your risks are and how you might be able to put together a model that makes sense.
Yeah, that's a really good point. I'll also add on the AI front, we didn't have time to talk about it in this presentation, but CMS does ask a lot of open-ended questions about how AI is being used right now in healthcare in the proposed rule. So if you've got a valuable AI solution that you're using, I highly, highly recommend getting to know those questions that they're asking and providing input to them so they can understand what the value of AI is in healthcare, how it's being used, and make sure that they're taking that into account when they're valuing codes and creating new codes and things like that. So it's definitely an important piece of that. We just didn't have time to cover it in here because it's kind of a different animal than what we're talking about here. But really important point. So we've got just 2 more minutes here. I want to get to at least a couple more questions. One question that I think is kind of a general question: what is a good format for submitting comments to CMS? This is a really great question. We always submit comments in PDF format. The bottom line is there's an online portal where you have to submit your comment. You can either type your comment into a text box that they give you, or you can upload an attachment to your submission. These are public comments, so you get a public tracking number and you'll be able to see when your comment has been submitted. But what I would say is to keep the formatting clean and make sure that you're able to get your points across really clearly. I would recommend drafting a Word document and putting it into PDF form and then submitting it that way as an attachment to your submission. And if you want the link for that, reach out to us. We've got the link to where you upload them. We're happy to share it. Okay, what other questions? So there's a question here about 99091 and whether it can be billed when data is self-reported versus automatically transmitted. 99091 is not mentioned in the proposed rule, nor is it mentioned in last year's 2021 rule. It is discussed in the CPT manual, though, which requires the same requirements as 453 and 454, where you have to use a medical device, and that medical device does have to automatically transmit data, does not include self-reported. Also, lots of great questions about what self-reported actually means. CMS has not defined that either. I think that there's a big difference between what we all on this call may think of as self-reported versus what CMS is meaning when they talk about self-reported data. What they are talking about is data that is not being collected from a hardware device and automatically transmitted to the provider. It's data that's getting put into an app or put into a journal or relayed over the phone, something where the patient has to actually manually enter information. That, like I said, that's a lot different than how doctors may traditionally talk about self-reported, but that's the distinction there. It's not being automatically collected and transmitted. It's being put in by the patient and then transmitted to the provider. And then this last question that I'll get to, any idea if 16 or more data transmissions will be required with RTM? Like I said earlier, I know that's a really big barrier for RPM in particular. It's not discussed in the proposed rule, but it may be worth asking CMS not to adopt that 16-day requirement for RTM if you think it's going to continue to be a barrier. And with that, I will ask Rebecca and Rima if they have any final points that they'd like to make, or if there's anything else that I missed. I also meant to put up this poll that I'm going to launch right now. Really quickly, if you could just let us know if you're going to submit stakeholder comments here, that would be really helpful. So Rebecca, Rima, any final points you'd like to make? Rebecca, you're on mute.
I mean, it's 2020 all over again. This has been very, very insightful. Thank you so much, Rima. Thank you so much, Caitlin. I encourage you all to visit our site through this link here. We do submit a large number of client comments on behalf of our clients each year. We have, I believe, been able to move the needle. It's really important to talk to CMS in sort of the language that they speak. I spent the beginning of my career working at CMS, reading comments and responding to them and writing regulations. So we do have in-house experience for how to sort of position ourselves for success here. Also, go ahead and check out our website. You can contact any of us through there, and our contact information is here. And we will be sure to, you'll be getting an email after this presentation with some links, and we will absolutely be coming back once the final rule is finalized this fall, this late fall, to let you know how to get prepped for 2022 and beyond. Thank you so much.
Yep, thanks everyone.
Thank you.